Hello everyone and welcome to UT Southwestern Medical Center. My name is John Guerin and I'm the Communications Coordinator for the Department of Radiology. Thank you for joining us today. January is Thyroid Health Awareness Month, so we're doing our part by discussing the thyroid gland and its role in regulating vital bodily functions such as body temperature, metabolism, and even heart rate. And we're here today with two of our UT Southwestern partners in patient care, Dr. Lori Wadamel, who is a radiologist with expertise in diagnosing diseases of the thyroid, and Dr. Fiemu Noriaku. Sorry about that, Doctor.
Okay.
He is an endocrine surgeon and the Associate Dean for Global Health, as well as a thyroid specialist. Before we get started, I want to remind everyone to make sure that you ask your questions in the comments section on your Facebook feed, and be sure to like and share this chat. As I said, this is a very timely topic because it is Thyroid Health Awareness Month. So we want to make sure everyone gets a chance to watch it who needs to see it and that we get some good traction today. Please remember that our physicians cannot comment on individual cases due to patient privacy laws. So with that being said, let's get started. First, for the basics. Dr. Noriaku, will you tell us about the thyroid gland? What is it and what does it do in the body?
Thank you, Jim. The thyroid gland is a small gland that's located in our necks. It is essential for almost every bodily function in our bodies. It regulates perhaps everything from our body temperature to our cardiac heart rate, and GI gastrointestinal motility. So it's not a gland whose function that we can't live without. Mm-hmm. So as far as we know, it's one that is an essential gland, but sometimes imbalances may occur where it doesn't make enough thyroid hormone, a situation known as hypothyroidism, or sometimes it makes too much thyroid hormone, a condition known as hyperthyroidism. Now, most of those situations don't require any special testing or surgery or monitoring, but they do require the services of an endocrinologist who's a specialist in function of the thyroid gland.
So if someone receives a diagnosis of either hypothyroidism, which is not enough activity in the gland, or hyperthyroidism, which is too much,
correct,
can that situation be handled or managed with medication? Or does it require removal of the thyroid?
Most of the time, especially in hypothyroidism, that can be treated with supplemental thyroid hormone. So a pill that you take it every day will replace, it's obviously synthetic thyroid hormone, and the trade name is Synthroid, which is sort of two words together, mm-hmm. Synthetic thyroid hormone, and that usually will correct the problem. Patients with hyperthyroidism may require some treatment to either stop the effects of the excess thyroid hormone on the body, or if that doesn't work, some people may require radioactive ablation of the thyroid or radioactive destruction of the thyroid to stop it from making all that hormone, or in some really severe cases, removal of the thyroid to stop the effects of thyroid hormone, excess thyroid hormone on the body. So traditionally, and as a first line of treatment, medical therapy or medicines can help with those conditions. But usually surgery is not indicated in those conditions except in specific cases.
But it is possible for a person to be able to live without the thyroid gland, despite all of its important functions in the body.
That's correct, only if they get thyroid replacement. So if they don't get thyroid replacement, then it's not compatible with life.
I see. Well, Dr. Wadamel, can you talk to us about your clinical practice? What is the most common thyroid disorder that you encounter?
Well, day to day, the most common thing that I would encounter are thyroid nodules. Approximately 68% of people at autopsy have thyroid nodules. They increase in number and prevalence with age. And with all the imaging that we do now of the body with chest CTs, spine CTs, and neck MRIs, we're discovering so many nodules incidentally in patients. So they come to my practice to further characterize them to help assess the significance and whether or not more treatment or evaluation needs to be pursued.
So you mentioned incidentally finding a nodule. What does that mean exactly?
So we may do a chest CT looking at the lungs, but part of the image may include the thyroid gland, and at that point we may see a nodule in the thyroid gland that is not causing the patient any symptoms but happens to be noticed and therefore prompts further evaluation.
And as a radiologist, you're obligated to report that finding to the referring physician, is that correct?
Well, that's a big part of the controversy about the thyroid nodules because so many people have them, and in most patients they're incidental, they're not causing any problem, they will never cause a problem. So part of our job is to help the referring physician and the patient know when further evaluation is indicated.
I see.
So we look at the clinical circumstances, and then we, based on the patient's age, the size of the nodule, they may go to further evaluation with ultrasound to help characterize the nodule. And we can look with ultrasound at many different features of the nodule and help decide whether or not that looks like a benign nodule, or if it looks very suspicious, or if it's a nodule that we just don't know and we may need to follow further.
Well, that brings up a question that we have from someone in our audience who's asking, when is a finding of an incidental nodule cause for concern? Dr. Noraka, would you like to tackle that question?
Well, as Dr. Watermore just said, an incidental nodule is a nodule that we find when the person has no symptoms of a thyroid nodule. And to answer the question of when it's a cause for concern, I would say, again, it depends on the size and some characteristics of the nodule. And I think this is where neck ultrasound comes in extremely useful, and Dr. Watermore may talk some more about that in a minute. But there are things like size of the nodule, there are things like the characteristics of the nodule, including whether it has calcium in it, whether it's got a lot of blood flow inside it or around it. These are all things that, as people say, make the nodule more suspicious. Also, in subsets of patients, very young patients, I would say less than 20 years old would be young to have a big thyroid nodule. And also, patients who are a little bit older. When we find nodules in those patients, it's a cause of concern. Because of the recommendations for many of our agencies now, any size more than about 1 centimeter with or without any of these features I described would be considered suspicious and would require additional evaluation.
Now, you mentioned as one of the characteristics of a nodule, its blood flow. Is that something that you can ascertain on ultrasound?
What we do is we have a number of characteristics we look at, and one of the most important things when we look at a nodule is it a solid nodule? The more cystic characteristics within a nodule points more to it likely being more a benign nodule. We look at the shape and size, the borders of the nodule, as Dr. Waryaku said, if the nodule has calcium within it, and the way its texture relative to the thyroid gland and the adjacent tissues. So we use a combination of the size and the sonographic appearance to grade it, if you will, to determine whether or not we feel that it needs prompt evaluation, potentially with a biopsy, or if this is a nodule that can be followed to assess for stability, to make sure it's not growing or changing in a more concerning manner.
So that brings up our next question, which is about follow-up. What kind of follow-up can typically be expected when an incidental node is discovered? So you mentioned monitoring the situation to determine if there's any change in the nodule. You mentioned biopsy. Can you talk a little bit about the types of biopsy that are done when one discovers an incidental nodule?
Sure. So the way we do our thyroid biopsies is with ultrasound guidance. It is a simple outpatient procedure that requires no preparation on the patient's part. They come to the department and have an ultrasound evaluation. We identify the nodule or nodules that need to be sampled, and using the ultrasound to guide us, we can watch the needle as it is introduced through the skin into the area of concern. We withdraw some material and submit it to pathology for evaluation. So it's a very simple, quick procedure.
So there's no need for a surgeon's scalpel or removal of big chunks of tissue or anything in order to do this type of biopsy?
Well, for a vast majority of nodules, the fine needle aspiration is diagnostic. There's a small percentage of nodules that do need to come out surgically in order to evaluate in the lab their borders and other characteristics that could narrow down whether or not this is a clinically significant nodule. But for most nodules, a fine needle is going to be diagnostic.
I see. And at what point would someone like yourself, a surgeon, an endocrine surgeon, get involved in this process?
Just like Dr. Bottomell pointed out, most of these patients don't require surgical care. When they get to the point of a definitive diagnosis of thyroid cancer, I think a surgeon, or at least a team of surgeons and radiologists and endocrinologists need to get involved. Also, when the final aspiration is unable to properly characterize the lesion as cancer or not. That happens about 10 to 15% of the time, and is when the report from the final aspiration, the cytologist or cytopathologist says that the biopsy is indeterminate. So there's a whole series of things that come under that umbrella, but that's usually when surgeons get involved with these patients, because in those cases one may need to have surgery just to remove that part of the thyroid to get a better diagnosis of the lesion, knowing fully well that it may not be a cancer, but that's the only way at that point to tell.
Can you talk to us a little bit about thyroid cancer itself? It's my understanding that there is an increase in thyroid cancer incidences, but that may be misleading, because it's possible that we're just getting better at detecting thyroid cancers that may have been there before.
I think that's very true. Our imaging modalities are now so much better at visualizing the thyroid tissue, so we're finding more nodules. And in finding more nodules, we're evaluating more nodules, and therefore we're biopsying more nodules and finding more cancers, which doesn't necessarily mean that these are things that are going to be clinically significant or that are going to affect the lifespan of the patient, but it is true that we're finding more.
And it's my understanding that there are 5 different types of thyroid cancer, is that right?
Roughly, broad categories, yes.
Okay, and can you tell us a little bit about the different types of thyroid cancer?
Without going into too much detail to bore people, I would say that the important things to know are that of the 5 types you mentioned, one type accounts for about 80% of the subsets. So the bulk of thyroid cancers fall into this group called papillary thyroid cancers. They're usually slow growing. They don't spread to, in other words, people don't actually get quick spread that grows to basically kill people in a short period of time. And they're usually easier to treat because they respond to almost all the types of treatment that we have now. So that I would say that about papillary thyroid cancer. The next most common type of thyroid cancer is called follicular thyroid cancer. They tend to be a little bit larger. They tend to be a little bit more aggressive. They spread through the bloodstream, and so they can, as we say, metastasize. They can travel to other parts of the body, even if they're not in the neck. And as a result, their outcomes, they're a little bit more aggressive, so the outcomes are a little bit poorer than papillary thyroid cancer. So those two account for probably 90+% of thyroid cancers. The other subsets are a lot smaller, and of those, I would say medullary thyroid cancer is one that deserves a little bit of discussion because most thyroid cancers arise out of the normal thyroid cell. Medullary thyroid cancer arises out of these packaging cells that are around the thyroid cells called C cells. And so when they form a cancer, they are very specific. The diagnosis is usually, they tend to also run in families. Medullary thyroid cancer has a more familial
So there's a genetic
predisposition,
aspect.
there's a genetic component to it. And although they're indolent and people survive a long time, they tend to come back frequently and require multiple procedures. And also they don't respond to things like radioactive iodine, which is something we use to treat most thyroid cancers. So I would say of all the thyroid cancers, those are the three big ones that we deal with regularly. Anaplastic thyroid cancer, which is perhaps at the other end of the spectrum from papillary, is perhaps the most aggressive thyroid cancer that we see. It's common in people who have had papillary thyroid cancer for a long time, so generally in older people, and it's extremely aggressive and can go from diagnosis to death in months to years. Frankly, most of the ones that we see, by the time they're diagnosed, don't come to surgery because surgery is not helpful, and they usually will treat them with external beam radiation and or chemotherapy.
So if a person receives a cancer diagnosis, are imaging people like yourself still involved at that point to help? You had mentioned before at the diagnosis and biopsy stage that you can actually help determine what area needs to be surgically removed. Are you still involved with the surgical team after diagnosis of cancer?
Well, at the time of initial evaluation, we make a point to evaluate the nodes in the neck and to assess the areas that are the most frequently involved with spreading to the nodes. And when we identify nodes that either are of a certain size or have certain internal characteristics, we will bring that to the attention of our surgical colleagues. At that point, we often will biopsy those nodes, especially if it will change the extent of surgery. And Dr. Wariaku may want to comment further on that. But we do help in that regard. Usually they don't need a full body assessment for thyroid cancer because the chance of it being spread to other parts of the body at the initial diagnosis is extremely uncommon.
I see. Well, we have a couple of questions that have come in from Pamela. She wants to know, do thyroid nodules ever go away on their own?
Actually, sometimes they do, especially cystic nodules can regress, and most of them don't disappear, but they can involute.
And her second question is, are there foods that should be avoided or diet that needs to be followed if you have nodules?
That's an interesting question. The short answer is not to our knowledge for patients with thyroid nodules. Now, for patients who've been diagnosed with thyroid cancer who require treatment, say radioactive iodine, we'll sometimes ask them to go on an iodine deficient diet. And the reasoning around this is our normal thyroids use iodine to make thyroid hormone. After we take the thyroid out, if you give people iodine, the way radioactive iodine works is we tag the iodine with a radioactive substance, and that is taken up by the cancer cells and kills the cells. If they're still taking iodine in their diet, that limits the effectiveness of that. So sometimes we'll ask patients to, after surgery, before radioactive iodine, to go on a diet that's low in iodine, and there's a whole list of things that they can't eat. But after that, no, there's nothing, and definitely for thyroid nodules, that I'm not aware of anything that says you should avoid certain foods or not.
I've never actually considered foods that have iodine in them. Are there common foods that would come as a surprise to people if they learned that there was iodine in those foods?
Bread and salt.
Salt, which is everywhere.
Of course, salt. I had thought.
So bread and salt are good ones, but fish. There are lots of fish, especially if you eat fish. If you're a sushi person and you eat fish that's a little bit higher up in the food chain, they tend to accumulate iodine from eating smaller fish and smaller things. So the higher up, if you're someone who eats mahi or tuna sometimes. So there's actually lots of iodine in our diet, and it's normally okay, but in some situations it can impair the efficacy of the treatments.
Well, tell us, where should a person who maybe they are concerned about nodules, or maybe they've discovered a lump in their neck, or they've talked with their doctor about the possibility that there could be a thyroid problem, where would be the best place to go for an assessment, a diagnosis, and follow-up?
That's a good question. I would say, before I answer the question, I'd like to I'll emphasize something Dr. Waddell said earlier, which is that the radiologists actually are never absent from the evaluation and treatment of these patients. So even though she mentioned that in the beginning, they look at the lymph nodes, they look at the thyroid nodule, they give you characteristics, they tell you where things might be. After surgery, especially in papillary thyroid cancer, the most common site for recurrence is in lymph nodes. And sometimes the recurrence is in the area where you took the thyroid out before. The only way we can confirm that is by the help of the ultrasound and another FNA. And if you look at the fact that these patients live for a long time, especially when they're younger, and the recurrences can appear anytime up to 20 or 30 years, the role of the radiologist is crucial. Having said that, the short answer to the question is that people who have these nodules should go to places where there's a team of people that do this kind of work regularly, that see patients with thyroid nodules and thyroid cancer and have some expertise in the ultrasound techniques, for instance, or the FNA techniques, or the surgery. I think sometimes when you get diagnosed, someone might say, well, we'll do this, but if something turns up that we're not sure of, we'll send you somewhere else. And then you're dealing with a lot of variability. There's already built-in variability in the system, but the variability goes up as you begin to stretch across groups that don't work together. Not that individually they're not good. It's just that if I send a patient to her and I say please look for this, sometimes she knows exactly what I want to look at because we do that every week. And sometimes I forget to say something, but she knows, so they order it and do it anyway. And so that communication between the team members is, I think, crucial for the outcome of the patient.
So you recommend a place with a multidisciplinary team?
Correct.
And I would like to emphasize that wherever you would go for your follow-up, as far as imaging, to have it be the same place each time. Hopefully a place that's used to doing thyroid, but we sometimes find little things in the neck after surgery that we don't know the significance. So we follow those. So we need the old studies to compare with. So by having your procedure done at the same place for follow-up becomes crucial to know whether or not something has changed and therefore it would become more significant in your care.
So you've mentioned ultrasound a few times today during our chat, Dr. Waddell. Are the other imaging modalities like computed tomography, CT, or MRI, magnetic resonance imaging, is it possible to detect incidental nodes in those other imaging modalities as well?
Ultrasound for the neck nodes is still the best study because we can look at the internal architecture to better advantage and find subtle things like calcifications or small cystic components in nodes that are clinically significant that may not be seen on other imaging modalities. So those other modalities, including more fancy studies like PET scans, are not used in the regular patient. They're used for problem solving or when people have more complicated or more aggressive disease. And at that point we may use the other studies, but really the workhorse in this disease is ultrasound.
And it just so happens that ultrasound is the least expensive imaging modality.
It is. It doesn't have radiation, and it is one of the more inexpensive imaging modalities.
I see. And of course, a question that comes in every chat we have is, are these sorts of tests covered by insurance? In other words, if an incidental node is discovered in another imaging test for something else, will the follow-up of that assessment, will that be covered by most insurance?
Yes.
Okay. All right. Well, we're just about to wrap up our chat for this afternoon. I sure want to thank you for joining us. As always, we will still be available to answer any questions that come in after the fact. As we end today, I'd like to thank Dr. Wadamul and Dr. Nwaraku for participating in our chat, and I'd like to thank all of you who've joined us live. Don't forget that this chat will be archived and here on Facebook and on our YouTube channel. We'll continue to receive your questions after this chat is concluded. So if you have need more information about scheduling an exam, or if you need to do a follow-up clinic visit, please let us know. You can call us at 214-645-8300 and request an appointment. Please share this chat with your friends and loved ones so that we can help spread the word about the importance of thyroid health. It could save a life, and that life could be your own.